Hi everyone, this is Christine Bauman. I'm going to start to go over my information on streptococcal pharyngitis. So we have a patient here who presents to the clinic. She is 36 years old, female, who reports to the clinic after having a sore throat for 2 days. She complains that she has some chills and body aches. She's taken Theraflu with no improvement. She reports her throat pain to be about a 6 out of 10, doesn't radiate anywhere else in her body. Nothing that she has taken has improved her pain, and she reports swallowing any liquids or solids makes it worse. She denies any traveling, being around anybody who's been sick at home or at work, and denies any abdominal pain, fever, chest pain, shortness of breath, headache, or dizziness. So first glance here, we're going to go through the review of systems. So her medical history, she denies. She's a healthy 36-year-old woman. She did have her wisdom teeth removed at 21 with no issues. She's got no known drug allergy. She does have some environmental allergies in the spring and the fall. She denies food allergies or latex allergies. She works as a third grade school teacher. She's not working currently because it is the summer. She lives at home with her husband and their 3 dogs. She denies having any children. She does state that she's in a monogamous relationship with her husband for the past 17 years. She's a good patient. She sees her OBGYN yearly, gets regular pap smears. She sees her primary yearly, has not had a colonoscopy or a mammogram at this time because she's not of the age yet. She sees a dentist twice a year, and she does see an allergist who manages all of her seasonal allergies. She denies smoking or vaping, denies tobacco use or illicit drugs, and she does drink alcohol occasionally when she goes out to, quote, date her husband. She takes Zyrtec once a day and Flonase once a day for her allergies. She does take ibuprofen occasionally, probably, she said, about once or twice a month after a long day of work with those third graders. Her family is pretty healthy. Mom and dad are alive. They both have hypertension. Mom's got anxiety and hypothyroidism, but dad only has hypertension and hyperlipidemia. Both her brother and sister are also alive and healthy. Maternal grandparents and paternal grandparents, they're both deceased, but you can see their history as you state there. So a review of systems. So we know that she's positive for chills because she reported that when she came in. She also says she's had a sore throat and she's had some pain on swallowing. She's denying any issues with her voice, in changes, any issues with the postnasal drip, denies any ear pain or eye pain. There's no shortness of breath. She is complaining of some myalgias, so, general aches and pains. She denies having a skin rash. No issues with her belly. She is able to eat food, no dizziness or lightheadedness, and she's had no issues in her behavior or any kind of psychiatric issues. So our objective data. So on our physical exam, her vital signs are stable, 36.7, pulse, respirations, you can see them all there. She's getting great saturations on room air, so that's fabulous. We did swab her. Our nurses did that when they first brought her in for the rapid antigen detection test. That's the RAT test, and that is positive for strep A. So it's important to note here that RAT test only is for strep A. If it comes back negative, it must be sent off for a culture to look for the other strains of strep. So rapid only tests for strep A. So on our physical exam, she's not ill looking. She looks pretty good. She doesn't look like she's had under any distress. Her ears and eyes are fine. Nose is fine. Sinuses are not any issue at all. They can be transilluminated. There's no pain there. Oral mucosa is fine, pink and moist with no lesions. However, the posterior oral pharynx is where she's having her problem. It's red and edematous with white pustules. Her tonsils are visualized. They're beefy, they're moist, they're reddened, they're swollen. White pustules are present there too. It's important to note that her uvula is pink and moist and it is midline. That's important. On her physical exam, the rest of it here, her lungs are clear, lung sounds are great, no adventitious lung sounds, no issues with her heart. She does not have any neck pain, which is important. No lymph nodes are palpable or tender, which is important. She does have no rashes or lesions or abrasions, no issues with her belly. Neurologically, she's intact, and psychiatric, she's in a good mood, and she's normal behavior for her age. So what are we thinking here for assessment? So she comes in with that throat pain, we are thinking streptococcal pharyngitis. Now, of course, that positive RAP test helps us to know that this is strep A positive, so this is what we're working with. The patient presented with an acute onset of throat pain, which is really common. That's the number one complaint with streptococcus strep A. So we call that group A strep, we call that GAS. So her tonsils are inflamed. She does have some redness in the back of her throat and some exudates. So that's all typical signs. So the differential diagnosis, that's those really bad things that we want to make sure it's not. It's very important that we look at those things and we're able to rule them out. So the big one here is peritonsillar abscess. So these patients usually do have a sore throat, but it is on one side of their neck. It's usually unilateral. They do have a fever, but they do have a muffled voice and they have a deviated uvula. That's why I was telling you it was important to notice that her uvula was midline. When there's a collection of purulent drainage that's in between the capsule of the tonsil and the muscle, it can be very swollen and it can actually cause an issue with an airway issue. So it is important that it's looked at right away and that we rule that out because that can be detrimental. We're also going to make sure it's not infectious mono. That also sometimes coincides with strep. And she's kind of still within that range. I mean, she's 36, she's a little older, but, this also has that pharyngeal, pharyngitis and fever. But the triad of symptoms here is sore throat, fever, but there's also posterior cervical lymphadenopathy. So that's that, and nuchal rigidity. So she does not have that. We are seeing a bigger incidence of this. I had read one study that said, with the incidence of vaping being so high in the 19 to 25-year-old range, they are sharing vapes, and that is driving up the incidence of mononucleosis, just as a side note. So our plan for her is pharmacologically, we need to give her some medication. We need to give her an antibiotic. So penicillin is the number one. So she has no allergies, so we're going to give her amoxicillin. She can have Tylenol or ibuprofen for her aches and pains or for the pain in her throat. Non-pharmacological plan, we're going to have her rinse with warm water and salts. Really, she can do this as much as she'd like. Gargle with it. It's good for cleaning out the back of the throat and helping with pain relief. She can use some Cepacol lozenges or, chloroseptic spray to help numb the pain. Cool or warm fluids to whichever one soothes her throat better. A lot of these patients like the warmth better. She should stay well hydrated and drink often. It's also important to let them know to change their toothbrush after day 3 of antibiotics, and that's to help prevent reinfection. Patients don't realize that your toothbrush can harbor a lot of bacteria. Education for her is to return to the clinic if she's not feeling any better or those symptoms worsen. However, if she does have any shortness of breath or difficulty breathing or problems with her airway that is emergent, you need to let them know they have to go to the emergency room. So what are our clinical guidelines here? So the guidelines here, the most common complaint for strep throat is a sore throat, right? But the clinical findings is you'll definitely find fever, sore throat, headache, body aches, sometimes a rash, usually with the younger population, painful swallowing, redness, swelling of the tonsils, and the white patches. But the things we're watching out for is our red flags here, and that's that unilateral throat soreness that we were talking about, neck stiffness, lockjaw, uvular deviation, drooling. They won't be able to swallow their own spit. It hurts so bad. They'll have a voice change. They can have stridor, or they can have that lymphadenopathy. So the differential diagnosis that can be, besides the ones that we talked about, the peritonsillar abscess, but it can also be retropharyngeal abscess, epiglottitis, Kawasaki disease, or an airway obstruction. So it's important to make sure that we have those red flags in the back of our head. Complications for untreated GAS. We're going to go over these in a little bit, but they're there. I actually have a separate slide just for the complications. It's important as a side note on the testing. Again, that rapid antigen detection test, that RAT test, that's the rapid one. The swab is a diagnostic tool that is a clinical guideline to use to differentiate between all those differential diagnoses. And it's pretty accurate and it's inexpensive. That's an easy test to have in a clinic or a primary care physician's office. And again, if that comes back negative, because again, the RAT test only tests for strep A. It is important, and it is a guideline. It's imperative to send off a throat culture. That's the ones that need to be grown after 3 days. That detects for other strains of strep, B and C as well. So it is important to send that out to make sure that we aren't missing anything or that the patient is being treated appropriately. So our treatment guidelines here. So again, the gas must be verified by those swabs. It's very important that they are positive. If they are not positive, it can be pharyngitis that's viral. In that case, no antibiotics are warranted. So we want to make sure that we're not contributing to the overuse of antibiotics. The number one gold standard for the treatment guideline for strep throat is penicillin or amoxicillin. If they have allergies to that, they can have clindamycin, they can have cephalexin, they can have Z-Pak. Reoccurring gas must be referred to ENT. It's very important that patients that have reoccurrent pharyngitis can be chronic carriers. It can be colonized in their throat. It can be something that's a repeated viral infection. They need to be seen by an otolaryngologist or an ENT because there must be some other issue there that can be possibly taken care of either from a surgical standpoint or more so than just a primary office. So complications of untreated gas. So, strep is strep, right? So it can be viral, it can be caused by an organism. If it is caused by an organism, it is very important that we find that out and that we treat it because the complications can be an issue. So they can have scarlet fever. That's that sandpaper textured rash that patients get on their head, neck, and trunk. They also have that strawberry tongue. The skin on the fingertips and the toes can peel away. This increases their risk of rheumatic fever, so it's important that this is caught early. Rheumatic fever is when that inflammatory process, reaction to the strep infection goes down to their heart and gets involved in their heart valves, their joints, and their brain. That can be life-threatening, so it's important to treat. Peritonsillar abscess, as we talked about before, that has that displaced uvula, the red bulging mass on one side of the pharynx, dysphagia, they're unable to swallow their own spit, they have a fever. These patients need to be referred to the ER right away. And that's because that swelling in the back of their throat can end up obstructing their airway. They can possibly need IV steroids and some IV fluids. So that's an important one that if you see that needs to be referred to ET stat. And the other one that I learned today or learned with this report is post-streptococcal glomerulonephritis. It's actually where the strep can get down to your kidneys and make them pretty cranky. So what will happen is the patient will have an abrupt onset of proteinuria. They'll have some blood in their urine or dark colored urine. So it's important to test these patients for strep. This can cause hypertension and generalized edema. So the next couple slides are the questions. 5 questions here to be looked at. And I thank you very much for listening to my slideshow.